All right, and we can get started now. Welcome, everyone, on behalf of the Myasthenia Gravis Foundation of America. My name is Larry McLean. I'm the Patient Services Coordinator for MGFA, and we're proud to present to you, as a part of our 2018 webinar series, Ocular MG with Dr. Rudrani Banik. We also want to take a moment to thank Alexion Pharmaceuticals for their sponsorship, of MGFA patient services. So before we get started, we want to make sure that we go over a couple of housekeeping items. We're going to mute the lines to ensure that we have a good sound quality on the call. In addition to that, if people forget to mute their lines, we'll get a lot of feedback and some background noises. You may type your questions in the chat area that's at the bottom right of your screen, and they will be answered during the Q&A session. Once again, we want to welcome you. We are proud to offer this program, Ocular MG, with our guest speaker, Dr. Rudrani Banik. Dr. Rudrani Banik is a board-certified ophthalmologist, fellowship-trained neuro-ophthalmologist, and functional medicine expert. She is fully trained in ophthalmic surgery and Botox, and she has special interest in treating headache and migraine. Dr. Banik manages a wide spectrum of conditions affecting vision, as well as complex connections between the eye and the brain. Dr. Banik is the founder of Envision Health NYC, a private practice based on the Upper East Side in New York City. She is an associate professor of ophthalmology at Mount Sinai Icahn School of Medicine. Dr. Banik has won many teaching awards and also serves as a principal investigator for 6 multi-center clinical trials in neuro-ophthalmology. She has authored numerous articles and has presented at national and international meetings. Dr. Banik is also a member of the American Academy of Ophthalmology's Exam Development Committee and helps to set the standards for board certification in her field. Dr. Banik is proud to bring more than 20 years of experience and her extensive knowledge of eye and brain combined with a holistic approach to her own practice. She is excited to have the opportunity to partner with patients with the goal of not only improved visual function, but also better health and quality of life. MGFA is pleased to present our speaker, Dr. Rudrani Banik.
All right. Thank you so much. Thank you, Larry, for that kind introduction. Can everyone hear me okay? Is the sound okay? Okay, wonderful. So we'll get started. Thank you, everyone, for joining. I'm sure you all have busy schedules, so it's wonderful that you have the time to participate in this webinar. I especially want to thank the Myasthenia Gravis Foundation of America for inviting me to present this very important topic to this audience. And I want to extend a special thanks to Susan Klinger, who introduced me to the MGFA group. It's a wonderful organization, and I'm very happy to be connected with it and the members. And I also want to thank Larry for helping to set this webinar up. So as Larry had mentioned, I am an ophthalmologist. I'm also a neuro-ophthalmologist. So I see quite a bit of ocular myasthenia in my practice. I've been practicing for about 20 years now, and I would say every week I diagnose at least anywhere from 1 to 3 new patients with myasthenia. So in my practice, it's actually quite common. In the general population, it's not so common. So, so what I'm going to be doing is, first, I'll just provide you with a brief introduction to myasthenia, just to review some of the background about myasthenia, and then I'll talk very specifically about ocular myasthenia and some of the symptoms that may arise from ocular myasthenia. And then finally, we'll end with some of the treatment approaches towards ocular myasthenia symptoms. So, so let's get started here. Okay. So first of all, what is myasthenia gravis? Well, as most of you already know, it's an autoimmune disease in which the body's immune system somehow becomes activated. And I say somehow because we don't really know what triggers this activation. But once it becomes activated, the body's immune cells begin to make antibodies against itself, almost as though it's fighting in a foreign agent, for example, a bacteria or a virus. So these antibodies are created against the body's own tissues, and these antibodies are called autoantibodies. And specifically in myasthenia, these antibodies target skeletal muscle groups. Now, skeletal muscles are typically our voluntary muscles. There are the large muscle groups that we use to move our limbs. They're the muscles that we use to breathe, for example, the muscles that we use to chew and swallow and speak, as well as the muscles we use to move our eyes and our eyelids. So in myasthenia gravis, these autoantibodies actually block the receptors on various muscles, and it prevents the muscles from contracting normally. And the result is weakness of the muscle. And the degree of weakness can vary. In some cases, it's mild weakness. In other cases, it's more severe weakness. Now, this diagram is basically just demonstrating first normal muscle contraction. So what happens in normal muscle contraction is that we have a nerve cell, which we call the neuron, and it's very close to the muscle cell. And the nerve releases a chemical called acetylcholine. And this chemical is released into the gap between the nerve and the muscle. The chemical then binds to a receptor on the surface of the muscle, and then that receptor stimulates a pathway that causes muscle contraction. And what I wanted to point out here is that on the surface of the muscle is actually not smooth. There are hills and there are valleys here. And this is a normal muscle, what we call a muscle end plate. And at the top of the valley of the hill is actually the acetylcholine receptor. So it's the receptor for this chemical that allows for muscle contraction. And what happens in myasthenia, so again, we have the normal, what we call neuromuscular junction or nerve muscle junction here on the left. And on the right, what we're seeing is that in myasthenia, these green upside down Ys represent the antibody. So the body produces antibodies that actually blocks the receptor itself. So it prevents these little molecules of acetylcholine from binding to the receptor. So you can imagine the more antibodies there are, the more receptors are blocked, and the worse the contraction may be. That's not always the case, but definitely the severity of muscle involvement will vary on the body's immune system and how much antibody is produced. So not only do these antibodies block the muscle contraction, but they also stimulate an inflammatory response. And what happens is with time, that inflammatory response actually degrades the receptor, and the receptor becomes internalized into the muscle, and it's no longer present on the outside of the muscle. So over time, there's also an anatomic change that's happening at the muscle. And I'll show you, let me just see if it's in my next slide, what actually happens as the muscle antibody receptors are degraded and then internalized. So here on the left, we see this image with a slightly different diagram, but same concept of the nerve. And then here's the muscle with its hills and valleys. And here are the receptors. These little nubbins here are the receptors for the acetylcholine molecule. And over time with chronic myasthenia, you can see that these natural hills and valleys have basically been destroyed. They've been smoothed out. And in terms of the number of the receptors, they're significantly reduced. So you can see here that on the surface of the muscle, there's quite a few, but here there's very few. And again, these little Y upside down Ys are the antibodies that are generated by the body against the receptor itself. So basically, there are fewer receptors and the muscle architecture is no longer normal. Now, this happens with chronic myasthenia and chronic inflammation produced by these autoantibodies. So you may ask, what actually causes this immune response? Why do some people develop myasthenia versus others who don't? Well, in many cases, we actually don't know. We don't know what actually triggers the response, but there are some theories as to what may trigger this cascade of events that leads to the autoimmune process. So in some patients, there may be a preceding viral illness, And there have been many viruses that have been implicated in myasthenia or triggering myasthenia. The most well-known virus is the Epstein-Barr virus, or EBV, which is the same virus that causes mononucleosis. Many of us have been exposed to it, but not all of us react in the same way in terms of developing an autoimmune response. Excuse me. Other cases of myasthenia may be triggered by certain medications, in which case we call it medication-induced myasthenia. And there's actually a wonderful resource on the MGFA website that is very comprehensive. It actually lists, or it goes through all the potential medications that have been associated with myasthenia. So some potential medications include something called D-penicillamine, interferon A. There are many antibiotics that have been associated with triggering myasthenia. And actually, I think according to that article on the website, almost every antibiotic class out there has in some way been associated with myasthenia. So it's not just one specific class, though some may be more predisposing than others. For example, aminoglycosides, which are gentamicin, tobramycin, that class has been associated with myasthenia, as well as the quinolones. So fluoroquinolone, levaquinolone, some of you may know it as levaquin. It's a common antibiotic used for many different things, from colds, bronchitis, to urinary tract infections. So these are very commonly used antibiotics which have been linked with myasthenia. There are some cases of myasthenia which are congenital. And in that case, many times the antibody is actually transmitted across the placenta from the mother to the fetus, and the child is born with myasthenia. It's a slightly different condition in terms of how it's managed, and in many cases it does resolve on its own. But then there's this very large category, which in medical terms we call it idiopathic, and what that simply means is that there's been an autoimmune response triggered, but we can't actually identify what this specific trigger has been. So it's not a specific virus or specific medication that was taken. It just happens. And so we call that idiopathic, which is what most cases do fall into this category of idiopathic. Now, what I also want to mention is that there's been quite a bit of research done lately, and it's ongoing research, to try to identify, are there genetic factors which predispose some people to myasthenia over others. And in fact, there are a number of genes that have been identified that are linked to myasthenia. Now, oftentimes, though, it's not the gene itself that causes the myasthenia, but when the gene gets turned on, that may predispose one to myasthenia. So it's not just having a genetic predisposition, it's also the environmental factors which may turn a gene on or potentially turn a gene on that make the condition develop. So potential environmental factors, there could be toxins in the environment, there could be, again, viruses in the environment or bacteria in the environment that may trigger it, or maybe it's some food that we've ingested, lifestyle factors, and I'll talk a little bit more about that later, but in general, stress is a major factor, and anecdotally, there are many, many patients who I initially see with their first symptoms of myasthenia who do report that they initially developed symptoms when they were under a tremendous amount of stress. So it's definitely something to consider, is the effect of stressors on our health and on our genetics. And it's actually an emerging field called epigenetics. Basically, how does our environment and our lifestyle contribute to the expression of our genes? So that's all being investigated. And there's hopefully in the next 5 to 10 years, there'll be a lot more research that's been published on the actual link between genetics and lifestyle. Okay, so I did want to mention that, while we're talking about autoimmune diseases do tend to go hand in hand. So oftentimes, if someone has a particular autoimmune disease, they're more likely to get others as well. It's not always the case. Sometimes it happens in isolation, but there are some specific autoimmune diseases that if you have myasthenia or someone you know has myasthenia, you should just be aware of. And I would say the largest autoimmune disease category that can go hand in hand with myasthenia is thyroid autoimmune disease. It could either be hyperthyroidism, which is known as Graves' disease, or hypothyroidism, which is known as Hashimoto's. And oftentimes in my newly diagnosed myasthenics, I will go ahead and order some thyroid blood work to look for either Graves or Hashimoto's because again, there is overlap between these conditions. Lupus is another autoimmune disease that can be associated with myasthenia, rheumatoid arthritis, type 1 diabetes, inflammatory bowel disease, whether it's Crohn's or ulcerative colitis, vitiligo, which is loss of pigment in the skin. It's an autoimmune condition as well, and alopecia, which is hair loss caused by an autoimmune condition. And this is just a very brief list. There's actually a number of other conditions that have been associated with myasthenia, which are autoimmune in nature. So now let's get a little bit more into the specifics of what are the symptoms of myasthenia, and specifically what are the ocular versus generalized symptoms of myasthenia gravis. So again, there are these two categories of OMG or ocular myasthenia. Yes. Yes.
Yeah, so we did have a couple of questions. Do you want to take some in this section right now, or?
Sure, we can do that. Should I go back? Let me just go back
Okay.
to the other screen.
Well, I can read you that.
Okay.
Carol has
Okay, so I see one
have you seen
question
any
here.
link with MG? Okay.
Yes, absolutely. So, specific to celiac disease, that's actually a whole several-hour lecture in itself, the potential link between celiac disease and myasthenia, but certainly celiac disease, which is really gluten sensitivity or gluten intolerance, um, can very commonly be associated with myasthenia. In terms of dystonia, there are many different types of dystonia. There are some, large muscle dystonias, smaller muscle dystonias. But in terms of what causes dystonia, some potentially may be autoimmune, but many are not autoimmune. Some may be caused by other neurochemical disturbances within the brain or muscles. So that I'm not as familiar with in terms of autoimmune dystonias linked with myasthenia, but certainly celiac disease. And in terms of one causing the other, I wouldn't say that one autoimmune disease necessarily causes another autoimmune disease. I would say that there is an overlap between these autoimmune diseases. And if one has a predisposition towards an autoimmune disease, it's more likely to get another one, but not necessarily cause another one. Okay, and then okay, any other questions before we move on? Okay, wonderful. So we can stop again for questions. So feel free again, if something comes up in the section that I'm speaking about, feel free to type in your question. So as I was saying, there are two large categories. Now, these are not hard and fast categories. There's no distinct condition called ocular myasthenia, but myasthenia is a range of symptoms, and in some patients they only have ocular symptoms, and that's why we call it ocular. But in fact, myasthenia is truly a whole body disease. It affects the antibodies are in your bloodstream. It can potentially affect any muscle groups, but for whatever reason, it tends to affect ocular muscles primarily. And generalized myasthenia is again the manifestation of symptoms within the body, but they're not clinically. I mean, we do distinguish between the two just in terms of how aggressive we are with the treatment, but they're not necessarily completely distinct conditions, and they're caused by the same process. They're both are caused by the autoimmune process. So let's talk a little bit more about, we'll first talk about ocular myasthenia. So this diagram basically shows all the various facial muscles that we have. And so these muscles are fairly superficial. Some are a little bit deeper. For example, some of the eyelid muscles are a little deeper, but some of them are quite superficial. And these are muscles that we use very frequently in our daily lives, whether we're speaking or smiling or chewing or coughing, we're using these muscles. And so the more muscles are used or certain muscles are used, the more likely they are to fatigue in patients with myasthenia. And there are a couple of eye muscles, which I want to point out here, that do tend to get affected very early on in myasthenia. So we have, there's a round muscle here, which basically is around our eye socket, and it helps us to close the eyes shut. It helps us when we squeeze our eyes. That's the muscle which is active, and that's called the orbicularis oculi. So that muscle can potentially get involved in myasthenia. And then there is a smaller muscle, which is actually underneath that muscle, or slightly a little deeper, which is shown here. It's called the levator palpebrae and superioris, and this muscle basically helps to lift the eyelid. And so these are, in terms of the eyes, these are some of the muscles which are primarily affected by ocular myasthenia. And I'll talk more specifically about symptoms that patients have when these muscle groups get involved. Now, this is another diagram, again, showing you this circular muscle called the orbicularis oculi. And this little muscle here, which is deeper, it's not actually that little, but it's just hidden by the other muscles, is called the levator palpebrae, which helps to, again, lift the lid, the upper lid. Now, there's another muscle here called the frontalis, and that muscle would basically be here, and that helps us to elevate our brow. And in some cases, that muscle can be involved as well with ocular myasthenia. Not always, but in some cases. Now, the other muscles that get involved in ocular myasthenia are the muscles that we can't see. They're behind the eye. And just to orient you, in terms of what we see on the eye, this is about what we see externally on the eye. But behind this iris and the cornea and the white part, which is called the sclera, are 6 muscles that help us to move the eye in different directions. So there's a superior rectus, which helps us to move the eye up, the inferior rectus, which helps us to move the eye down, the medial rectus, which helps us to move the eye inwards, and the lateral rectus, which helps us to move the eye outwards. These 4 muscles are the most commonly affected in myasthenia. There are 2 smaller muscles which help us to rotate the eyes mainly, but those muscles for some reason tend not to be as involved in ocular myasthenia. So out of the 6 muscles, 4 of them are most likely to be involved in myasthenia. So let's move on here. And again, these muscles attach behind the eye or on the outside of the eye. We don't see them. Normally, these are not visible. They're deeper in the eye socket, and they attach all the way back. They're fairly long. They attach all the way back in the back of the eye socket. Now, let's talk about some specific symptoms that can happen with ocular myasthenia. One of the most common symptoms which patients develop initially is something called ptosis. And it's actually spelled Ptosis, but it's pronounced ptosis. And what it basically means is a drooping of the eyelid. And we can see here in this photograph that this young woman has asymmetry in her eyelids. One is a little bit more open than the other. And this one is about at half mast. It's blocking her vision. It's about halfway down, blocking her pupil right here. And so this is a potential feature or finding in ocular myasthenia. Now, this is another case in which a patient has bilateral ptosis or drooping of the eyelids. And you can see that this is pretty significant. The patient's vision is really quite significantly affected, especially his superior vision is blocked. And many patients, when they have this amount of ptosis or drooping, they will adopt what's called a chin-up position. Because if they keep their head straight, they don't see very well. So they align their heads like this to be able to see, to look down beyond their drooping eyelids and be able to see. So, so that's a very common kind of head position that patients adopt. Now, this is showing you, this image here is showing you pretty significant ptosis. Both eyes are affected fairly symmetrically, but the reason I put this image in here was in the presentation was because I want you just to be aware that what this patient is trying to do is he's trying to use his eyelids to lift his eyebrows to lift his eyelids up. So this is again a very common feature of ocular myasthenia is that patients will, if their brow muscles are working fine, they will really try to elevate their brow to be able to see better. And in this patient here, you can see not only is he adopting that chin-up position, but he's also really trying to recruit these eyebrow muscles to try to be able to see properly. And he has a pretty severe ptosis or drooping of the lids. Sorry, do we have a question? Okay. So I'll just continue
Yes,
on, and
Rhonda
again,
had a
feel free to
question.
interrupt. Okay. Larry, would you just like to read the question to me?
Sure. Is nystagmus or asclepica, I'm sorry if I said that incorrectly. I'm sorry, I lost
Sure.
it. Associated with ocular MG. This was my first symptom, but I was told it was not associated with MG.
So that is correct. It is not a common feature of myasthenia gravis. Nystagmus is when the eyes jiggle, they don't stay steady. And in myasthenia, there's weakness, but the jiggling is not a feature. And so we really have to look for other causes of that nystagmus. Oscillopsia is basically the symptom of jiggling, which is seeing your environment shaking or jiggling. So it's not a steady environment. It's an environment that's in flux. It's constantly moving. So nystagmus is the clinical term for jiggling of the eyes, and oscillopsia is the symptom of jiggling of the eyes, but neither are associated with myasthenia. So again, if you have that or if you've been diagnosed with that, we really need to look further to figure out what is causing that, because it's not the myasthenia. Do we have any other
There was a
questions at
second
this point?
question.
Sure.
Why is it sometimes asymmetrical? Why wouldn't it affect both eyes equally?
So that's a wonderful question, and I have many patients ask me that all the time. We don't know. All I can answer is that our bodies are not perfectly symmetric. Sometimes one limb is a little longer than the other, and in myasthenia, sometimes one eyelid is more affected than the other. And the same holds true for the muscles that move the eyes. You know, why are some muscles affected but not all of the muscles? So there really is no clear answer to that, you know, why one lid may be more affected than the other. In many times, though, many circumstances, a patient will come to me complaining of one lid that's problematic, but when I look and I examine the patient, it's actually both eyes that have the issue. And I'll just go back a couple of slides just to point out the first image that I showed you. So in this patient, you know, we're all drawn to the fact that her right eye seems to be at half mast, but when I look more closely, when I actually do measurements, I can tell that this lid is actually not as open as it should be either. So in fact, this is a bilateral case of ptosis or drooping. It's just that one eye is much more affected than the other. But in fact, this one is affected as well. Normally, the lid should cover only the top 2 millimeters of the colored part of the eye or the iris. So you can see here that it is a few millimeters lower than it should be in this patient. Any other questions before
We had a question. Can surgery correct double vision?
Okay, wonderful question. So I'm actually gonna address that a little bit later in my talk. That will definitely I'll address that question in just a few slides. Okay, any other questions before we move on? Okay, wonderful. So I'll continue. So another key factor of ptosis associated with myasthenia is that the symptoms get worse as the day goes on. So it's something we call fatigable. The ptosis or lid position is fatigable. And so this is a wonderful example of a patient who has myasthenia, and in the morning, his eyelids are fairly open. You know, his lid is maybe a little bit lower on this side, but it's not blocking his vision. But by the evening, you can see that this lid is over 50% lower than it was earlier, and here it's also pretty its position is lower than it should be, and it's significantly affecting his vision. He can't see out of this eye because of the lid obstructing the vision, and this eye is also significantly affected as well. So this is one of the key features I always ask my potential patients about, patients with potential myasthenia about, is does your lid position get worse as the day goes on, or when you're tired, or when you're exhausted, or perhaps after a few drinks at night? It's a very common symptom is that the lid position will slowly diminish over time or decrease over the course of the day. Now, I also did want to mention that in my practice, I see quite a few children, and I have quite a few children who have myasthenia that I take care of. And many times in children, the ptosis may be very mild. And as you can see here in this, I'm sorry, that's a little pixelated, but it's very subtle that this child actually has a tiny bit of a lid asymmetry. This right eye, the lid is about 1 millimeter lower than the other eye. And so oftentimes it can be missed because it could be very subtle. The other common missed finding is that many children who have a little bit of a droopy eyelid will be misdiagnosed with ocular allergy or dry eyes, or just having had rubbing their eyes often, causing a little bit of drooping of the eyes, when in fact it's actually myasthenia. So I can't mention, I mean, there are many children that have been referred because they have this eyelid issue that doesn't go away, and looking very closely, ultimately some of them do end up with the diagnosis of myasthenia. So again, even subtle ptosis can potentially be myasthenia in some patients. Now, this is another child, and another aspect of ptosis in children I did want to mention is that this is obviously it affects his function quite significantly because the lid is pretty much blocking his entire vision. But when a child is developing, their visual system is developing, it's very important for both eyes to get equal input to the eyes so that the brain can process the signal and vision can develop properly. When it doesn't develop properly, then there's a potential for lazy eye, or what we call amblyopia later in life. And when a child has this much ptosis, that the vision in that eye will not be able to develop properly. So it is very important for these children to get properly diagnosed and to get treated, especially before the age of 10. Because after the age of 10, the visual system sets in, and we've almost lost our window to help to promote visual development in that eye. With the worse eyelid position. So it's just another consideration in children. Now, another common feature of myasthenia is, as I'd mentioned before, the eye muscles getting involved, which can cause double vision, or what we call, the medical term is called diplopia. And basically all this means is that the eyes, instead of being properly aligned, are not aligned. And the medical term for that is strabismus. So in this patient right here, what we're seeing is that one eye is looking straight, but the other eye is drifting off and up a little bit. So there's a misalignment there. And the eyes can actually, in myasthenia, they can deviate in any direction. It can be vertically misaligned, horizontally, or even diagonally, as we see in this image here. Now, strabismus or misalignment is not only caused by myasthenia. I just put this in for a little bit of trivia. So there are many people who have strabismus not caused by myasthenia, many famous people, including Abraham Lincoln. So if you look closely, his eyes look fairly normal, but I'll just point out to you that, in fact, if you look very closely, his left eye is actually a little bit higher, and you can see it in this diagram as well, in this photograph as well. His left eye was actually higher than the right. And it's been noted in the historical textbooks that when he would become fatigued, his eye would actually drift up even more. So this was a strabismus that was fluctuating. Now again, I didn't put this in here to suggest that Abraham Lincoln had myasthenia, but just to say that there are many people who have strabismus or ocular misalignment who live full, healthy lives and do everything that they need to do in their daily lives. So it's very possible to live a fruitful, healthy, successful life with strabismus. And I will talk to you about some ways to manage it specific to myasthenia. So I just also want to mention a couple of maybe some more technical terms you may hear if you have strabismus. You may hear your doctor using these terms. But when an eye is turned inwards, now this is a pretty significant misalignment. It's called esotropia. Eso meaning crossed in. And then when one eye is turned outwards, it's called exotropia, meaning the eye is drifting out. And so these are very important. Being a neuro-ophthalmologist, I really do measure how much deviation there is. Is it fluctuating? And in myasthenia, it's very interesting that the misalignment can fluctuate. So on certain days, a patient may actually come in with an esotropia, and later, maybe on a different visit, or even later within the same visit, half an hour later, that misalignment may change. So in myasthenia, there can be quite a bit of fluctuation in the double vision or in the strabismus. The same with the lids. The lids can fluctuate quite a bit, even minute to minute. Sometimes the lids fluctuate. So it's a very common feature of myasthenia is this fluctuation. Vertical misalignments are
Dr.
called
Banik?
hypertropias. Yes,
So we have two questions.
sure.
First, I have a question from Roger. He said, diagnosed with MG from Fanapt. Symptoms all stopped when antipsychotic was stopped. Is drug-induced MG still MG and may reoccur?
Okay, I'm sorry, Larry. The audio cut out just as you were speaking, as you were saying the question. So maybe what I'll do is I'll go back to the chat and I'll see what the question actually was. If you don't mind, I'll just switch over here. Okay, so I'm not familiar with this very specific antipsychotic, Fanapt, but as I had mentioned earlier, there is a very long list of medications which have been associated with myasthenia or potentially unmasking myasthenia or triggering a myasthenic syndrome. Now, as to whether that means that this is causing myasthenia long term, that really is something that you should discuss with your doctor. Whether you have antibodies or you don't have antibodies or some of the other testing was positive or not. In certain cases, I've seen many cases where patients have been put on a drug, it caused myasthenia-like symptoms, the drug is discontinued, and the symptoms resolve. And we call that drug-induced myasthenia, but there is a chance that even those symptoms have resolved, that at some point in the future it may flare up again. So it's not always clear cut in terms of whether the drug is the only causative factor or perhaps that the drug simply unmasked an underlying tendency towards myasthenia gravis. I hope that was able to answer your question. Okay, so I see another question here. Are there glasses with some tint that could help disguise the ptosis? So in terms of ptosis, there are specific types of glasses that can be used, but in terms of cosmetically blocking the ptosis so that others can't see the ptosis, yes, you could wear dark tinted glasses. There's no tint that will specifically, or at least has been shown to specifically improve ptosis in itself, but in terms of it making it less cosmetically obvious, certainly a dark tinted glass, whether it's a gray or brown or black tinted glass, would help to cover up the ptosis. Then I see another question here. Watery eyes, blurry vision is also a common symptom of ocular MG, or is it a secondary effect? So vision will be blurry for many reasons. And so the vision can be blurry because it's double, but the tearing can be another feature which may or may not be associated with myasthenia. For example, if one has a weakness of the circular muscle around the eye, which is called the orbicularis oculi, if that muscle does not close fully, if it doesn't have the strength to close fully, your blink will be a little bit weak. And when our blink is weak, then there's a chance that the surface of the eye will dry out. And then that dryness can cause tearing. It may seem contradictory, why would dryness cause tearing? But in fact, what's happening is the cornea or the surface of the eye dries out, and then the tear glands kick in, they overproduce tears, and that's what causes the tearing. So my response would be, if you're having tearing, then consider putting in some lubricating drops to see if you can prevent the tearing. And again, in some cases that is specifically associated with myasthenia, but on the flip side, there are many patients who have tearing from dry eye that don't have myasthenia. So it's not very specific to myasthenia, but it can be caused by weakness of some of the eye muscles. Okay, and then I see another question here. Photosensitivity, is this common with myasthenia? This is a very similar question, or my answer will be very similar to the watering, the tearing question. So there are many patients who have light sensitivity who don't have myasthenia, and then there are patients who have myasthenia who have light sensitivity. So whether one is causing the other, it's very hard to distinguish. But I have had many patients tell me who have myasthenia that when there are bright lights, whether it's sunlight or artificial light, when there's a lot of glare, they feel like their lids just want to close, or their double vision or their blurry vision gets worse. So it may be independent or it may be linked. There are some specific tinted glasses that I sometimes recommend for patients who have significant light sensitivity. And if you wanted to discuss that, we can perhaps chat at another time to talk about some options in terms of tinted lenses. Okay, any other questions right now? Okay, so I will, if there are no more questions right now, I will go back to my presentation. So, okay, so as I was mentioning, when the eyes are vertically misaligned, it's called a hypertropia. So you can see in the top diagram that this patient's right eye is significantly higher than her left eye. This child has the left eye being higher. Sometimes the eye is lower, and sometimes it alternates. Again, myasthenia can cause fluctuating symptoms, so day to day, minute to minute, it may change. So I'm just going to just very briefly talk about some of the symptoms of generalized, and then we'll talk about treatments for ocular myasthenia. So I'd mentioned before that patients who have myasthenia, the antibody is in the bloodstream, so it can potentially affect only the eye muscles or manifest in only the eye muscles or potentially affect other muscle groups as well. And in this diagram here, this is showing you all of the skeletal muscles in the body. They tend to be large muscle groups that help move our bones. The breathing muscles also, which are in between our ribs that help us expand and contract our ribs. So these muscles can all potentially be involved in myasthenia. And then in some cases of myasthenia, it's not just these muscles that can be involved that can cause weakness throughout the rest of the body, but specifically within the face and the head area, head and neck area, there are muscles that help us move our jaw, which is the major muscle here is called the masseter muscle. It helps us to chew, it helps us to speak, and so patients may experience weakness in that muscle. So this is beyond ocular myasthenia, and in cases like this, I would diagnose the patient not just with ocular myasthenia, I would consider the diagnosis of generalized myasthenia because these are beyond just the eye muscles, even though they're facial muscles, beyond the eye muscles that are involved. Now, there are also muscles here which are called the bulbar muscles, and these are the muscles that help us to swallow and they help us to speak. So these muscles can be involved as well in myasthenia. So I always ask my patients, do you have any trouble swallowing? Does food get stuck in your throat? Can you only swallow soft foods or liquids and not hard solid foods as well? Those are some potential symptoms of generalized myasthenia when these bulbar muscles get affected. Another question I oftentimes ask my patients is, do you have any hoarseness in your voice? Does your voice get raspy? If that's the case, then it may be due to myasthenia as well. And sometimes I do co-manage patients with voice issues with my ENT colleagues or voice specialists to help manage their other issues. So again, this is beyond just ocular myasthenia. These are symptoms of generalized myasthenia. So as I mentioned before, just some basic symptoms that I always ask about: trouble breathing. Can you not get enough air in? Can you not expand your chest? Do you feel like you have tightness or shortness of breath? Difficulty swallowing or chewing, hoarse voice is what I just mentioned. And this is a very important question. Weakness of the neck. So the neck extensors are muscles back here that help keep our head upright. And many times patients who have generalized myasthenia will feel as though their head just wants to droop down. They don't have the strength to keep their head upright and their neck straight. And so oftentimes patients will come in like this, and those muscles are just not working. So if those muscles are involved, I would call that generalized myasthenia. And the other muscle groups that do tend to get involved are the shoulder girdle muscles. So another question I tend to ask is, can you lift your arms above your head? Can you comb your hair properly? Can you wash your hair? Can you reach for something without your arms or shoulders getting tired? So these are some other symptoms that may suggest that a patient has symptoms of generalized MG versus just ocular MG. Okay, so next we're going to be talking about the treatment of ocular myasthenia. Now, before I move on to that, I just want to ask any questions about this past section that I just covered, about double vision or ptosis or even generalized myasthenia.
Yeah, there are a couple of questions if you want to view them.
Sure. Okay. Okay, so how can you prevent ocular MG, MuSK, to progress to generalized MG? So I just want to clarify something here. I didn't really talk about the diagnostic tests that are used to diagnose myasthenia just because of the limited time that we have. But MuSK is a specific antibody that is found in certain cases of myasthenia. And it's very interesting. In ocular myasthenia, when it's pure ocular, the MuSK tends to be negative. So it's almost as though with ocular myasthenia, it's not expected that the MuSK will be positive. MuSK stands for muscle-specific kinase. So ocular myasthenia can progress to generalized myasthenia. If it progresses, we believe that based on some of the studies that have been done, that it will happen within the first 2 years of diagnosis. And this is the general time frame that I usually mention to my patients is, if you've gone more than 2 years with the diagnosis of ocular myasthenia and you do not have any of the other symptoms of generalized myasthenia, the likelihood that you will progress to generalized myasthenia is low. I'm not saying it's zero. There is still a small possibility, but it's much less likely. There's also been there have been some studies that suggested that patients who are treated early on for ocular myasthenia with immunomodulatory treatments, for example, steroids or other treatments that help to modulate the immune system, may have a lower likelihood of progressing to generalized myasthenia. And we usually, because of that reason, I usually recommend treating early and sometimes more aggressively to try to prevent generalized symptoms from developing. Okay, so there's another question here. Does the skeletal system carry the burden of lack of muscle strength in GMG, resulting in injuries such as meniscal tears or skeletal pain? So unfortunately, being an ophthalmologist, I'm not qualified to really answer this question. Many of my patients who do have symptoms of generalized myasthenia, I co-manage them with a neurologist who specializes in generalized myasthenia. So I manage the ocular symptoms, and my colleagues manage the generalized symptoms. So I don't really know if the stress or the weakness produced by generalized myasthenia would predispose someone to developing potential injuries to their joints, their bones, their ligaments, their tendons. I don't know. I wouldn't be able to answer that, so I apologize for that. Okay, so now there's another question here. Does one progress to the other usually? Not usually. As I said, if it does progress, usually it's within the first 2 years. That's not a hard and fast rule, but in the majority of patients, it's the first 2 years are most critical. And then we have another question here. I've had OMG for 5 years. Do I need to be cautious and avoid known triggers that might cause the MG to generalize? So this is a very important question. You know, can you do anything to try to prevent generalization? And I would say treating aggressively early on with specific medications that your doctor may deem appropriate, as well as trying to adjust your lifestyle to reduce stressors and potential other lifestyle factors. Now, as Larry mentioned in the very beginning, I also practice functional medicine, and I'm a very firm believer that nutrition and lifestyle factors can significantly impact chronic disease. And there are changes that you can implement within your diet as well as your lifestyle to try to minimize the risk of some of these these autoimmune conditions from flaring, whether it's ocular myasthenia or something else. And unfortunately, because of in the interest of time, I won't really be able to go further into those topics. But yes, there are ways to try to minimize your risk of having generalization or flare-ups, either with medications or with medications in conjunction with nutrition and lifestyle factors. Okay, so I apologize. I think we only have a few minutes left, and I do want to try to finish this presentation and stay on time. So I will go back to the presentation. Oh, sorry, let's see here. Okay, so let's just talk the last few minutes that we have. We'll just talk a little bit about the treatment of ocular myasthenia gravis. So the treatment is really aimed at reducing the symptoms. So based on what the symptoms are, in some patients it's double from strabismus, and in some patients it's a drooping eyelid, or in some patients it's a combination of the two. So my treatment is for either of these conditions or both of these conditions is really customized to the patient, and so there are different approaches that can be used. Medical approaches for either medical approaches, medications, or specific types of glasses, and then surgical approaches for each, for both the strabismus as well as the lid position. So let's talk again. We don't have that much time left, but I'll just very briefly go over what some of these treatment approaches can be. So in a newly diagnosed patient with myasthenia, ocular myasthenia, I usually start with Mestinon, which is pyridostigmine bromide. It's a cholinesterase inhibitor, and what it does is it prevents the breakdown of acetylcholine so that the acetylcholine can last longer near the connection between the nerve and the muscle and potentially work to stimulate the muscle. So this is a medication which is given orally, either as a tablet or it comes in a suspension for pediatric patients. The tablets are 60 milligrams. There is also an extended release formulation which is available of Mestinon. So again, what Mestinon does is this is a healthy nerve muscle junction, a neuromuscular junction, and this is one with myasthenia. So you can see that the acetylcholine is released, but it's blocked, and so there's what we call an enzyme called cholinesterase, which comes and degrades the acetylcholine. And so if that comes in and degrades it, there'll be even less acetylcholine available to try to stimulate the muscle. So what Mestinon or pyridostigmine does, it basically blocks that enzyme so these neurotransmitter molecules can last longer. So the issue with Mestinon is that it is temporary. It has a very short duration of action. Usually it lasts anywhere from 4 to 6 hours at the most. So the dosing needs to be multiple times during the day. Some patients need to take it 3 to 4, even 5 times a day, because again, the body metabolizes it fairly quickly, and within just a few hours, its effect wears off. But in some patients with ocular myasthenia, this is sufficient to try to control their symptoms, and patients do quite well on this. Now, there are some potential side effects. Sometimes patients can have cramping in the stomach, loose stools. If that's really an issue, there are other medications that can be used to try to counteract that, the GI side effects. The other side effect, which some patients do complain of, is a fine twitching of their muscles. So sometimes it's the facial muscles that twitch, sometimes the tongue or the lips, sometimes even the fine muscles within the hands can twitch. And this is because of Mestinon. Now, if a patient has side effects, I usually tell them If there are unbearable side effects, just wait it out. Within 4 to 6 hours, the medicine will be out of your system. And if it's really not, if you're not able to tolerate the side effects, then we can discontinue the medication. But oftentimes, what happens is patients initially have these side effects, and with just continued therapy, the side effects diminish and they become more tolerable over time, and eventually they disappear. Other treatment for myasthenia, again, in the interest of time, I'm gonna go very quickly through some of these slides. Mestinon treats the symptoms, but it doesn't really get to the root cause of myasthenia, which is the autoimmune response. And much of the treatment for myasthenia is really aimed at to try to reduce the production of antibodies by our immune systems and to prevent destruction of the acetylcholine receptors and prevent destruction of the muscle. Because once that happens, we really are, the medical treatments are no longer effective. So the most common treatments, and I'll just skip through some of these slides, are prednisone oral steroids, or in some severe cases, patients do require intravenous steroids if they're really in a crisis situation where their muscles are extremely weak. Sometimes IV steroids are required. There are other agents that can suppress the immune system, which also work very well. Azathioprine is a common agent that's used. It's called Imuran. It helps to suppress the production of autoantibodies. In some patients, Cellcept or mycophenolate mofetil can be used, and in other cyclophosphamide, which is called Cytoxan. And perhaps some of you are on these medications or have been on these medications. What I tell patients is that any medication can potentially give side effects, and especially these medications that suppress the immune system can potentially give side effects. Each has its own side effect profile. So if you are on any of these medications, you really have to work closely with your doctor, your treating doctor, to make sure that you're not having any side effects or long-term issues. For example, many of you know that prednisone can be associated with diabetes, high blood pressure. It can actually trigger diabetes or worsen diabetes. So it's a discussion that you really should have with your doctor as to whether these medications are necessary, and if they're necessary, are they appropriate at the doses given, or can alternative medications be used? There are other treatments as well that can be used. These are a little bit more aggressive. Plasma exchange or plasmapheresis, which is basically it's a filtering of the blood. It requires catheter placement, so it's an invasive type of procedure, usually done in a hospital, or IVIG, which is also an infusion. In this treatment, external intravenous antibodies are given to try to bind up the autoantibodies that are causing the myasthenia symptoms. The limitation of this is it does, in some cases, work very well, but it does have to be given regularly in some patients on a monthly basis or bi-monthly basis to maintain its effect. Now, there are newer medications on the horizon that some doctors are using to treat myasthenia. Biologics are a category of disease that are being explored, and the one that I will mention is rituximab, which is also called Rituxan. It's given as an infusion. It helps modulate the B-cell response, and there are some studies suggesting that it can be very effective. The issue is that it is quite costly, and it requires insurance approval, and so oftentimes it's not the first-line agent used, but it is a potential agent that your doctor may choose for you. And there are other biologic therapies that are being developed which may be more specifically targeted for myasthenia, not just a general kind of a immune suppressive treatment, but specific to myasthenia and the antibodies that are produced in myasthenia. So that's something to look forward to in the future. Now, in terms of other types of therapy, so thymectomy, which is removal of the thymus gland, which in some patients is thought to be associated with myasthenia. So in terms of generalized myasthenia, it has been shown in a large clinical trial that was published in 2016 in the New England Journal of Medicine. It has been shown to be effective in terms of long-term control of myasthenia, but that was for generalized myasthenia gravis. In terms of patients who have ocular symptoms only without generalized symptoms, that study has not been done yet. And that is a study that many doctors would like to have that study done, but it is a difficult study to do for many different reasons that I won't go into today. But thymectomy, if you have generalized myasthenia, may be an option or a good option for you. Again, please speak with your doctor about that. Now, in terms of strabismus, specific to myasthenia, so I measure strabismus, the neuro-ophthalmologist measures strabismus using what we call prisms, and we actually do prism measurements, and we monitor the measurements over time to see whether it's fluctuating, whether the condition's under control. So in terms of using prisms, sometimes, we use the prisms for diagnostic purposes, but sometimes prisms can also be used for treatment of strabismus. Now, this is what we call a press-on prism. Some of you have probably been treated with this or may have seen this before. It's called a Fresnel prism. The S is silent, so Fresnel. And what it is basically, it's a clear plastic. I mean, it looks white here because it's laid against a white background, but it's actually a clear, flexible plastic material. And what it does is it optically corrects for the double vision. So it optically realigns the image onto the back of the eye to try to eliminate double vision. And this can be very effective with one caveat. In myasthenia, the amount of strabismus has to be stable. If the strabismus is fluctuating, this is not going to be a good option because we decide how much prism to give based on the measurements. And so you can see here that this is a 12, what we call a diopter prism. So it's a very specific measurement in terms of the strength of the prism. And so again, if the strabismus is fluctuating, this is not the best option. It actually is not a good option. Now, prisms can be applied to glasses, and some of you may have remembered several years back when Hillary Clinton, this was in the media, she was actually wearing a prism here. So this prism is malleable. It actually sticks. It's self-adhesive. It sticks onto the back of glasses. It's clear, but you can see the fine lines or the prism lines within the prism. So from a distance, it probably will not be noticeable, but up close, it is noticeable. The other thing I did want to mention about wearing a Fresnel prism in glasses is that the prism, because it has the fine lines, it can blur vision just maybe by a line or two. So oftentimes one eye will be a little bit blurrier than the other. So the eye with the prism will see a little bit more blurry. And that's something that I just tell patients about ahead of time. The double will be improved, but the blurriness may be a limiting factor in terms of whether a prism is best for you or not. I do want to mention that Hillary Clinton does not have myasthenia. She had double vision from a different reason, but prisms were used in her case. Now, if someone has strabismus and they're not doing well in terms of they're not responding to medications, whether it be Mestinon or an immune suppressant, then and if the measurement is stable, with the prism measurement is stable, then surgery may be a very good option. And the surgery is called strabismus surgery. And it's done by a surgeon, and usually an ophthalmologist who specializes in strabismus surgery. And what is done is basically, if the eyes are misaligned, for example, if one eye is turned in or the eyes are turned out or one eye is higher, the muscles are moved behind the eyes to realign the eyes. And in some cases, the muscle is cut and it's reattached to the eye, it's strengthened. The muscle is strengthened to realign the eye. And in some cases, let's say the muscle is drifting out, the eye is drifting outwards, the muscle is taken off the eye and moved to a different position to weaken the muscle to allow the eye to go into a more normal position or straight position. So this is called eye muscle surgery. Again, different types of procedures can be performed, and this is just showing one muscle that's being operated on, but there can be a combination of various muscles that require surgery, especially with a complex pattern of strabismus that can happen in myasthenia gravis. And some patients do very, very well with this type of surgery. This is a young woman who had myasthenia. You can see her eyes are drifting outwards, and she was not responsive to medications. And after strabismus surgery, you can see that her eyes are very, very well aligned, and her double vision resolved. Now, I do want to also mention that in some patients, after surgery for strabismus and myasthenia, the eyes may be close, but they may not be perfectly realigned. And if that's the case, sometimes a second surgery is needed, or perhaps even a third surgery is needed to fully correct the problem. Or sometimes after surgery, if the eyes are brought much closer together and there's a small amount of residual double, then prism glasses can be used after surgery to alleviate that residual double vision that's present. Now, in terms of eyelid drooping, surgical approaches or medical approaches, so in terms of glasses, now I thought this was a little interesting. These are called eyelid crutch glasses. So there's a piece of metal that's welded onto the frame of the eyeglass. And so this is looking at it from up above, but basically what is done here is this is a patient, I'm sorry, the images are a little bit blurry, but this is a patient with significantly drooping eyelids. And this crutch, the eyelid crutch, actually inserts under the eyelid skin and it mechanically lifts up the eyelid. So this can be effective. You can see here that the patient improved significantly from this lid position to wearing his eyelid crutches. His lid is open. But I do have to mention one very important word of caution is when the eyelid is mechanically opened, it's not able to blink properly, and the eye is at significant risk for drying out. So eyelid crutch glasses are not the best option for everyone, especially if there's concurrent dry eye. It's really not a great option because the cornea could dry out significantly and cause many other problems, such as even corneal ulcers. So in very limited situations do I recommend these types of glasses. It's actually, within the US, it's actually very difficult to find opticians who can actually make these glasses. They've really gone out of common use, so it's very hard to find manufacturers who will be willing to make these eyelid crutch glasses. Now, surgery is sometimes indicated and may be appropriate if medications don't work for ptosis. So in this situation here, this is the previous picture I showed you. This woman had a significant ptosis, and you can see that after surgery, her lid looks very symmetric. So she had an excellent outcome after surgery. There were different surgeries that can be done to try to lift the lid up. Sometimes I had mentioned there are different muscles that go around the eye. So sometimes one of the muscles is tightened to actually lift the eyelid up. And in other cases, there's actually what's called a sling or a silicone tube band that's put in. It's actually under the skin. It goes from the brow to the eyelid, and it actually helps the patient use their brow muscle to raise their eyelids. So it's recruiting their brow muscle to help raise the lid, which is very effective. So you can see both of these patients here actually had slings done, and both had significant ptosis before, and afterwards their lids are in much better position to allow them to be able to see. Now, the dry eye issue can still be a problem after this kind of surgery. So it's just something to keep in mind. Definitely speak with your ophthalmologist or oculoplastic surgeon about this if you're being considered for surgery. Ask the doctor, am I at risk for dry eye, and how can dry eye be limited, or the severity of dry eye be limited by the type of surgery that's best for me. So it's a very important discussion to have prior to surgery. So finally, I would just want to finish with this. I did mention a couple of times during the talk that I'm a strong believer that aside from medical approaches and surgical approaches to ocular myasthenia and generalized myasthenia, that nutrition and lifestyle are extremely important. And there have been quite a few patients in my practice that I have put on very specific diet and lifestyle recommendations. And if patients are able to comply, now there are customized diets, and some of the diets are a little difficult to do because they're very strict. But if a patient is able to follow the diet, I have been able to get several patients off of their immunosuppressant medications and be managed with diet alone, which is really remarkable. Now, this is, I do have to say, it's not mainstream, and it's not a substitute for medications. It's an adjunct. So I use nutrition and lifestyle in my practice as an adjunct to the traditional medical and surgical approaches to management of myasthenia, specifically ocular myasthenia. And in terms of my recommendations, I usually prescribe very specific diets. Most of the diets are anti-inflammatory in nature. pro-antioxidant. I also recommend very specific ways to help to try to reduce stress. Meditation is wonderful. I don't know if any of you do any kind of meditation on a regular basis, but it's a great way to try to reduce stress. Adequate sleep and rest. I can't say enough how important this is. And many of you will know that if you don't get adequate sleep, then the next day myasthenia can definitely flare. It can, and it's very fatigable. It can definitely worsen. So even sometimes naps during the day can be very, very helpful. In addition to that, I also recommend visual rest. So for many of you who use devices, computers, smartphones, tablets often, your eyes do get tired. You know, when we're looking at a screen for hours a day, our eyes will certainly fatigue. And so I also sometimes recommend visual rest for many of my patients. Hydration is very important as well as movement. Now, notice that I didn't say exercise because in some patients, exercise may worsen symptoms of myasthenia, and it's a very kind of an individual prescription that I give to patients in terms of how they can incorporate some degree of movement into their daily routine. It may be something, for example, like chair yoga, or certain eye exercises that I recommend. But movement is also very important, even in patients with myasthenia who have the risk for weakness and worsening symptoms with exercise. It's very important for general health and well-being. So I think I'll end there. I apologize, I did go over the time a little bit, but if you have very specific questions about anything I presented today or any of the topics I've discussed or just about your own very specific unique condition, I do offer phone consultations. I offer 10-minute telephone consultations. Now, in these consultations, I cannot diagnose you, I cannot be your treating doctor, but I may be able to help point you in the right direction if you have very specific questions about what to do next for your symptoms. So if you're interested in scheduling a phone consult with me, you can visit my website, which is right here. It's my full name, which is www.rudranibanickmd.com. On my website, there is a specific webpage where you can book a virtual appointment for a phone consult. Alternatively, you can call my office and you can speak with one of my assistants and you can set up the phone consult that way. I usually do my phone consults on Mondays, so we can find a time on a Monday that would work for you. Again, it's 10 minutes, complimentary, and we can talk about some specific topics that you may have. And then lastly, I would just like to invite you all to join my Facebook group. It's called Envision Health, and in this group I talk about a lot of nutritional approaches to health and wellness, not just specific to myasthenia, but overall health and wellness. For example, I talk about what are the best foods for vision health and brain health. And then I also talk about some lifestyle recommendations specific to vision. What are some ways that that you can try to protect your eyes against certain potential toxins or certain lights? Blue light, I know, is a topic that has been controversial. So I talk about all those different topics, and you can post a question, and then we can have a forum, a discussion to try to see what other people's thoughts are about that topic. So I invite you all to join my Facebook group, Envision Health, or again, set up a phone consult with me. I also have a lot of other information on my website about nutritional approaches to vision health and brain health. So you can take a look at some of the blogs that I have posted and download some of the materials I have. So I think I'll close there, and I'll go back to the webinar screen. So again, I think we're a little bit over time here. We're at 8:20. So again, I want to thank you all for participating. I really enjoyed giving this talk, and I hope it was helpful. I hope that I gave you some information. I taught you some new things that perhaps you didn't know, or I answered some questions that were helpful to you. So thank you. And again, Larry, thank you so much for helping to set this webinar.